Good evening. Welcome to our webinar hosted by the San Mateo County Dental Society. Thank you for joining us today. My name is Ben Yount and I'm the president of SMCDS. Before we get started, I want to review how we'll be running this meeting. All participants will be placed on mute. Our presenter will provide a presentation on bioaerosols versus dental aerosols. During the presentation, you may post a question into the question and answer box. For those participants on your desktop, the question and answer box is located on the bottom of your screen. For those on an iPad or iPhone, the question and answer box should be in the upper right. Please feel free to post your questions, and if time permits, we will go over them at the end. So now let's get started. Tonight's presenter is Dr. Bruce Bohannon. Dr. Bohannon has been practicing oral and maxillofacial surgery since 1998. He is an honor graduate of UOP Dental and graduated with distinction from the University of Missouri, where he received his medical degree and completed his residency. He became board certified in oral maxillofacial surgery in 2000. He maintains private practices in both Burlingame and San Jose. So please welcome Dr. Bruce Bohannon.
Can you guys see my screen? Are you guys able to see my screen? Yes? Okay.
Yes, yes, see it.
Very good. All right, so let's get started. So of course tonight, I probably wouldn't have been here because it is opening night and the Giants are playing, right? So we got to root for our team. This is a first sign of normalcy, okay? So at least we got baseball started. Certainly there's no fans, but it's at least a good start. And let's hope the team has some good luck tonight against the Dodgers. So aerosols, it's an interesting topic because there's a lot of data going around about bioaerosols, which are the aerosols that we generate from our bodies. And we're being confounded into that same set of circumstances. And then there's still a lot of talk about masks, and then are masks causing people to be hypoxic and build up CO2? And then are we safe, and what are the best practices that we can employ? If you've ever been at a beach, you can't see it coming, but you can feel the spray of the mist on your face. Or here we can see the mist. Now that's not an aerosol. What you can see isn't, but these people along the street, they're not in the cloud, but they feel that on their face. So that's what the aerosol is. So a quick review, the modes of transmission of COVID-19 is direct, and that's probably the most common way people are going to get infected, and that's through a direct or indirect or close contact with the infected person. Through respiratory droplets, which are usually droplet size greater than 5 microns. And then when they get less than 5 microns, that's when we're going to refer to them as droplet nuclei or aerosols or micro droplets. And the reason I put aerosols in italics is because aerosols can vary in sizes very greatly. So some of these definitions are used independently in different articles, but just try to keep in mind they're less than 5 microns in diameter. So there's a debate over actual sizes, but again, these are mostly the accepted size ranges. Respiratory droplets remain when a person is in close contact with an infected individual. Respiratory droplets that include viruses can reach the mouth, nose, or eyes, wherever that mucosa is, and then that's where an infection can result. Indirect contact is with when somebody is infected and they touch or place a droplet of a certain size on a fomite, which is an inanimate object. You touch it and then bring it into your respiratory tract, and then you can catch it that way. And so for a long time, a lot of the research was showing that really maybe airborne transmission doesn't really happen. And again, the majority of transmission is through droplet, but airborne certainly looks like it is a possibility given particular conditions. So an airborne transmission is defined with the spread of an infectious agent that is disseminated the droplet nuclei that remains infection when suspended in the air for a period of time, and it can spread over long distances depending on what the environmental conditions are. Spread through aerosols in the absence of aerosol generating procedures, because we're trying to not confound us with bioaerosols, particularly indoor settings with poor ventilation seems to be the areas where airborne transmission is definitely possible. So to understand bioaerosols, to understand dental aerosols, you gotta understand a little bit of the flow physics. Okay, the flow physics or the biophysics as well as the fluid dynamics. And then we're gonna understand that there's a few articles that are repetitively referenced when you hear experts from the CDC or the government and certainly the media that sensationalize these aerosols. So we're going to look into each one of those articles and pick them apart a little bit. So the transmission process, the flow physics is the key to the transmission of COVID-19. Each stage of transmission process is mediated by a complex flow phenomenon. Basically, this isn't that simple of a thing. There's a lot of moving parts within a cloud that's a bioaerosol that's generated. So you have air mucus interaction. The air flowing over the mucus that's along our respiratory tract causes liquid sheet fragmentation, turbulent jet flow, droplet evaporation, deposition, flow-induced particle dispersion, and sedimentation. So again, try to understand there's a lot of things going on. Understanding fluid dynamics and the biophysics is paramount in understanding the disease transmission. Until that is fully understood, it's difficult to create targeted mitigation efforts depending on the environment of the disease. So like we said, that the respiratory droplets that then fracture off into these droplet nuclei and stasis and referenced on old data going back to 1934 and the Spanish flu pandemic observations from 1918. Only similar events that we can see where we had such a social restriction in place were the polio outbreaks of the 50s. Respiratory droplet, the generation, expulsion, evolution, transportation of droplets and aerosols generated from the respiratory tract during expiratory activities such as breathing, talking, coughing, and sneezing. Understanding how these are generated, determine the number, the density, the size distribution, and the velocity is critical to understanding how this disease spreads. We need to determine what the critical size of the droplet is that transmits the disease. Is this a small droplet transmission route, or is it multifactorial? We need to estimate the settling distance for different droplet sizes. We need to characterize the transport of small droplets in the droplet nuclei of the air and quantify external factors such as air currents, temperature, humidity on all the above, environmental areas or volume, how air, the dilutionary effects of non-stagnant air affects the droplets. Respiratory droplet formations from fluid from the lining of our respiratory tract, and they're created in specific areas of the tract. And that's going to be important because we talk about dental aerosols and we're liberating it from the mouth. The virus really doesn't live in the mouth. It lives down farther in the respiratory tract. So a lot of the respiratory droplets are influenced by each person's respiratory tract anatomy. That's why everybody's different. Nobody's going to expel the same amount of droplets. And that's multifactorial between the amount of disease, the amount of viral shedding, how much mucus do they have, how hard are they breathing, what's their anatomy. So it's quite complex. So we have to understand airway elasticity, mucus saliva productions, as well as the viral load carried by the lining of the eventual fragmentation of the mucus lining due to the shear stress induced by airflow. So the rupture of the fluid lining during the opening and closing of the respiratory passages actually determines the velocity of exit. So how big I open my mouth or narrow determines the velocity that it's leaving, because that's the barrel of exit. So imagine you have a water hose, and then you see the flow of the hose, and then you go ahead and put on you know, whatever your gardening tool is that creates the jet. You'll see that the speed of the water is quite a bit higher, and it goes much farther. So we know that terminal bronchioles, the inhalation and exhalation of these opening and closing, causes stresses of the mucus lining over tissues. It fractures them off. They carry them up higher into the larynx. More mucus that contains disease is fractured off during talking. And then the movement of the mouth and tongue, again, changes the caliber of the exit point, which changes the ballistic effect of the cloud that's emitted. So droplet characteristics include density, velocity, and size distribution. Sneeze has a velocity of around 44 miles an hour. If you look at some reports, I think they're sensationalized, especially the one on WebMD that says they've calculated at 100 miles an hour and contain up to 10,000 droplets. I've seen other studies that say 100,000 droplets. Most of the studies, I think, will be around 10,000. So a cough, a little bit less velocity than a sneeze, is around 22 miles an hour, and it generates somewhere between 10 and 100 times less droplets, again, depending on what paper you read. Talking, you can produce about 50 particles per second with speeds around 5 meters per second or less. Now, this is important. The droplet sizes range from 0.1 microns to 1,000 microns, but the majority are 0.5 to 2 microns, and 5 to 10 microns are the next size. So about 80 to 90% of expired droplet size, whether you're talking, coughing, sneezing, singing, yelling, whatever, is going to be between 0.25 and 5 to 10 microns, with the majority being the 0.25 to 0.5, okay? Breathing generates droplets at a much lower rate. It accounts for expired bioaerosols over the course of the day. Various episodic events like sneezing or coughing can add to the volume that's distributed within a particular environment. So the longer somebody stays in a closed environment that doesn't have any kind of airflow or ventilation, these things will build up slowly over time. And we know that over time, your exposure over time equals transmission when we're looking at an airborne spread disease. So what effect does evaporation have on these bioaerosols? Droplets affect the survivability of the envelope virus, such as SARS-CoV-2, which means as soon as they are out of their protective droplet, that lipid envelope that they have around themselves actually desiccates extremely fast. Surface saturation or the vapor pressure of the surrounding air is humidity dependent, meaning if I'm in a room that's very cold and I expel a hot, humid gas, it's going to rise and stay higher in the air for longer periods of time, because humidity or air that has more water pressure in it actually displaces nitrogen and oxygen, which I believe is molecular weight of nitrogen 17, oxygen is 18, and H2O is quite a bit lighter than that. So it can stay suspended for quite a long time when you have humidity differences. Plus, we know hot air rises. So hot air plus the humid air in a dry, cold room will stay up for a long period of time, and we'll actually show that in a video. So the survivability of envelope viruses such as SARS-CoV-2 is dependent on all these factors. It cannot survive long outside its protective droplet. Airborne transmission, the small droplets suspended and transported in the air currents. That's something that you need to really take hold of, that if you can have just a little dilutionary flow of an air current, a lot of these droplets are simply washed away. However, 10 microns or less can stay suspended in a stagnant room. And when they get smaller, so 0.3 microns or smaller, they go through what's called Brownian motion. Brownian motion is a phenomenon where they're so small that they actually start colliding with molecules in the air, and they have a very irregular pattern of distribution. However, with all of those collisions, they can stay suspended longer. However, Brownian motion is also why filters in your mask can catch things that are smaller than what they're rated to catch, meaning a lot of HEPA filters can catch stuff that are 0.1 microns when they're only rated maybe a half a micron. And the reason is this Brownian motion. It's so irregular. Imagine louvers in your shades that are just big enough to accept a BB. If you throw that, or if you drop it right down that space, it'll fit. But now if you turn those louvers a little up and try to throw it in there, oftentimes it won't hit. And the way these masks and filters are is they have a little electrostatic charge. So if it doesn't pass straight through, it just ricochets off a corner, it gets stuck. So that's important to know about Brownian motion. So most droplets that are larger than 10 microns fall really fast. And that's why you'll also see in hospitals why almost every shoe cover is testing positive for the virus, because the heavy expired large particles just go straight to the ground, right to the shoes. That's why it's important you leave your shoes at work, okay? Most droplets evaporate very quick. The resultant particle of these smaller droplets, when they get even smaller, they're called the droplet nuclei, a few viral particles and very little fluid. And it's just virons and a little bit of solid residue mixed with a small amount of fluid around it. The biggest factor in how far and how long small particles stay suspended is the ambient airflow. Cannot stress that enough, ambient airflow. Okay, inhalation of bioaerosols is the final step to infection. Virus travels to the respiratory mucosa. Virus-bearing droplets in the respiratory tract does not always result in infection. Mucus layer provides protection, your anatomy provides protection, your individual immune response CoV-1. It's possible that it's you need 10 to 20 times less. However, I don't know if that's a linear extraction or is it logarithmic. I don't know, and I haven't found any research to tell us what an infectious dose is at the moment. So larger droplets ricochet off your anatomy, leading to your glottis, okay? The smaller particle size, the farther it gets farther and farther into the tract, the smaller it is, the farther and more penetrating it can be. Sizes less than 5 microns can penetrate deep into the respiratory tree, but the critical size is 2.5 microns or less, because they pass right through a lot of our body's defenses and get to where they want to get to. So current recommendations are based on archaic studies dating back to Wells' work in 1934. More recent studies on aerosol dynamics have issue-based on their design. The studies are very poorly designed, and we're gonna point these things out. Results from measurements are highly variable, secondary to indirect measurements using properties calibrated on biomaterials. So the way they're measuring things is really wrong. They shouldn't be doing what they're doing. So the accuracy of the results are very inaccurate. It's limited because the results are given in a static result. Not much is learned from a static reading, but we need to know about the size, the size of the droplets, the nuclei, how it moves and acts in a variety of atmospheres over time, not a snapshot reading. So dynamic results are few and sketchy at best because they're taking snapshots through this evolution of a cloud. So an ideal study would be direct measurements. You could quantify the properties of the aerosol. You could calculate its size and speed, the humidity, the temperature, the volume, the density, the evolution over time in whatever environment you're testing it in. With concepts of fluid dynamics applied to a sneezing cloud, it can be determined that the cloud is multi-phase. It has a gaseous phase, we know that, air expelled and various gases within it. There's a fluid phase of the droplets within the cloud. There's a solid phase after evaporation, and what is left is the droplet nuclei and the residues. So there's a lot going on, and nobody's really looked at all that together. So understanding cloud dynamic flow by high-speed camera imaging, varying lighting techniques, image extraction, and mechanistic modeling is something that is needed so we can understand these aerosols. The sampling of the clouds and lab tests to the content, the infectious ability of each portion of the cloud is also not studied that I can find. An aerosol is just not an aerosol. It's a cloud comprised of many different sizes of droplet gases, particulate matter, humidities, and other components. So once again, like I said, it's a complex, dynamic, moving unit. They all have interplay with each other in the environment they are expelled into. So if I expel it outside, that's quite different than if I expel it into a cold, small, stagnant room. The environment plays a lot into how this cloud develops. Each cloud is emitted by a host. The host varies as well. The size of the host, the content, the concentration of whatever they're expelling. A sneeze, it's a cloud. It's not an isolated drop. It isn't large versus small. It's a cloud that is dynamic and ever-changing. It's turbulent. It's high energy flow that creates a swirling pattern. You'll see this in a seemingly disorganized fashion, yet it follows deterministic patterns on average. As it's emitted from a point source, your mouth, your nose, it starts off small and grows as the eddies and the turbulent swirls on the outside expand and they bring in the ambient air, creating a bigger cloud. It slows the speed of the cloud, but it starts to grow. The more static the ambient air is, the slower the cloud becomes. Buoyant, as it is hot and moist that we already talked about. Lighter when compared to the surrounding cold air. Cloud traps droplets within it as a continuum, not large versus small, and there's some videos that depict this phenomenon very well. So watch start to stay suspended, and you can see how far this thing starts to get very quickly. So it follows more of a ballistic pattern. So if you look here, if you look on the right and on the left, you'll see that swirl, that pattern of swirl that's there, bringing in more ambient air surrounding it, creating a bigger cloud and a far-reaching cloud, okay? Turbulence leads to expansion, as we talked about with the eddies of the swirling cloud's perimeter. Bioaerosols, though, resemble, again, a ballistic pattern, a dental aerosol. When we shoot the dental aerosol into a relatively closed cylinder, which is what our mouth is with the pharynx being the back wall, it's more of a ricochet-generated aerosol, not a ballistic one. So the biophysics of a dental aerosol versus a bioaerosol are radically different. Okay, cloud enhances the range of all drops. We got that. Up to 30 times for drops 30 microns or less. So these things can get pretty far. In a completely controlled room, they got to sneeze to go 27 feet. Again, controlled room, stagnant air, cold. somebody at the perfect angle and probably a big person, but they got it to go 27 feet, okay? So you can imagine that in a stagnant room, a whole room can quickly become engulfed with just a few sneezes and coughs. And over time, if there are multiple people in that room, you can get the concentration up pretty good. And without airflow coming into the room, it can stay there for quite a long time. The dynamics and biophysics of the cloud must be incorporated in any assessment and modeling of transmission of pathogens, but you also have to take the environment into those studies. How does the host physiology change transmission under varying conditions? And how does this influence the model of transmission, again, in different environments? And how does this all relate to the susceptible individual? Everybody's different, number of viruses, number of droplets, varying characteristics of the exhaled cloud. What about the host? What about their ability to disperse the pathogens in a turbulent flow? Everybody's different. And again, it depends on the environment of which it's happening. Determine the implications of such dispersal and the persistence of the pathogen and how it's detected early to determine preventative mitigation actions. Meaning, if you understand how these things work, you can much better design a mitigating countermeasure to counteract what's going on with the virus in different situations, okay? Especially different environments. So if you understand the mechanics and the dynamics, you get a much more accurate model. And remember, emission is only first step in the transmission chain. Dispersal, persistence in the environment, exposure to the new host, to these clouds, its biophysics and the biophysics and the of the recipient, okay, not only the host, but also the potential person becoming infected is also required. It leads to better designs of indoor spaces when you understand the dynamics of these clouds. It optimizes response to high impact pathogens prior to drug therapies and vaccines, and continues to reduce exposure after vaccines are being delivered. So again, if we understand how this works, we can be much better in selecting our environmental controls, our PPE, our engineering controls, and what screening methods should we be doing to reduce the chance we're seeing these people. It would lead, again, much better designs of indoor spaces. It would allow first responders to be better prepared and equipped when intervening and interacting with an unknown pathogen. And we certainly, or this won't be the only one that we may see in our lifetime. So if we understand how these things work, we'll be better prepared for the next one. And so here are some of the things that, that are alarming about aerosols, but it is very interesting to note that when you watch some of these things, what is left out in the media? They always show the aerosol that stays suspended for minutes or hours. They never show what happens when you have air current. All of these tests are done in a very controlled environment, intentionally trying to sensationalize the aerosol to see what its potential is in a perfect set of circumstances, the perfect storm. But there's very few times where that actually is going to take place, but it may show us why there were some super spreading events, meaning if we look in some of the deep south, there were some contact tracing going back to a church choir practice. But if you look at where they practice, it was a very small room. It has no ventilation. Video.
The team will track particles in the air using laser beams and a high sensitivity camera.
And at the beginning of the pandemic, these videos were shown innumerable times on CNN, Fox, and most of the news channels.
The experiment starts. First, sneezing. We can see a large droplet about 1 millimeter in diameter. It quickly falls. But let's look through the high sensitivity camera. We can see small particles that seem to glitter floating through the air. These particles are all smaller than 10 micrometers, or 1/100th of a millimeter in diameter. Let's take a look from a different angle. They're small and light. You can see them drifting through the air. These are microdroplets.
Right, pretty scary stuff, right? And it can be in the right situation, but let's see on this side what happens when we're just talking.
We ran the same experiment on a close-range conversation. People generate a lot of microdroplets when they talk loudly. The droplets between these two stay where they are. They don't drift away.
And now they show what can happen with these microdroplets when you're in a controlled space. And again, you saw these printed in online news outlets, as well as the videos showing again and again at the beginning of the pandemic.
About 10 people in an enclosed space the size of a classroom. A person coughs once and spreads about 100,000 droplets.
I think 100,000 droplets is a fairly big exaggeration.
Most of these fall to the
it's usually
ground
around
within 1
10.
minute. But the microdroplets shown in red continue to drift. This simulation uses only microdroplets. 5 minutes later, 10 minutes later, 20 minutes later, the microdroplets are still floating in place.
Okay, so pretty scary stuff, right? The perfect storm. Non-airflow room, very stagnant, probably cold, and they can stay suspended and dispersed for quite a long way. But let's show what they always left out in when they showed this these videos. They always left out this part.
Increasing air circulation is believed to be effective. When you open a window, microdroplets are quickly swept away.
Okay, and this holds true too in Germany.
They're very small and light, so any airflow will get rid of them.
They have very few clinics that have very modern HVAC systems in a lot of the areas in Germany. So what they did is they simply open their windows so they have air coming in all the time. And we know that the Germans used level 3 masks throughout the entire pandemic for the most part, and we saw no clusters of infections in Germany, and they worked through the entire pandemic. And they attribute that a lot to the open air clinics that they have. So if we really look at the turbulent gas flow emissions from this lady, who's a very smart lady from MIT, she is the one who came up with the 27-foot sneeze. Again, it's designed to be in a perfect environment that's designed to exaggerate and sensationalize the aerosol, but she's doing it, if you read her article, just to understand the fluid mechanics and the biophysics of sneeze or a cough to understand the cloud that's generated. But it is impressive. But it's not a real world setting, which is unfortunate because these are the things that are quoted and misquoted and misinterpreted by a lot of our experts. I see people from the CDC quoting this. And while it's, yes, it's solid research, it's not a real world setting. So unfortunately, we get recommendations and we could even get mandates that are based off this type of data that can really affect our practice. So the biggest study was the one that came out of the New England Journal on April 16th. This is the one you saw all over TV, and it's still being commented today, where the aerosols stayed suspended for 3 hours. And these were found to be fomite active on cardboard and stainless steel, plastic for days. Now, some of that research that they did, if you look at it, was actually pretty decently done. And I think some of this fomite study that they did was actually pretty decently designed. However, how they designed the aerosol portion of the study has a lot to be desired. Because it's also a letter to the editor and not a peer-reviewed study, full disclosure of the methods was not fully transparent. So let's look at how the study was contained. They, first of all, created the simulation of the expired ballistic gas with a 3-jet collision nebulizer, which is up in the upper right corner. Okay, it's up top, it's over here, okay? That is used for biosimulation simulations. So to show how it would affect if some sort of bioterrorism gas was released in a subway. So it's very high powered, but it can also be used to test the aerobiology of an organism. But the device is a very exaggerating device. But more importantly, they took the bioaerosol and they put it into a Goldberg drum. Now just take a look at this Goldberg drum. It's a stainless steel drum that has a controlled environment, temperature, humidity, pressure, everything's controlled within it. And they put that in there and then rotated this drum around. Does this look like a real world room or something that we would find really in everyday life? I don't spend a lot of time inside a drum or a cylinder, but this is what they did. And they took samples out of this drum at 0, 30, 60, 120, 180 minutes, okay? So this clearly was designed to exaggerate and sensationalize an aerosol, and that's exactly what they found. They stopped the test after 3 hours, and they found that, the virus was still there and was still capable of transmitting disease. They took it to a lab and they did cell cultures, and sure enough, it had the capabilities of transmitting disease. But they don't tell us, did they pass airflow into this? Was this truly a open environment, or was it closed like the experiment looks like it was? They never really opened the Goldberg chamber except to take swab samples of the air at those particular intervals. So we are getting decisions and recommendations based off this letter. So the test really is invalid for any kind of implication to a real world setting. Okay, there are lots of papers about SARS-CoV-2 and the routes of transmission. Again, at the beginning, it was respiratory and maybe fomite. It definitely is not airborne. However, I think studies are coming around the corner that are definitely showing that there is an airborne component. A lot of people are saying that the airborne component is the main mode of transmission. Clearly, it is not. But in certain conditions, in certain environmental conditions, airborne, with little or no airflow in a stagnant room with recirculating HVAC system, it certainly can be a transmission route. And I think Teller said it best. If there's ongoing contradictory findings in multiple studies, like with he was commenting on the influenza virus. It may be more likely that various transmission routes, direct, indirect contact, short-range droplets, long or even short-range airborne droplet nuclei, may predominate in different settings, making airborne route for that particular pathogen more of an opportunistic pathway rather than the norm. And I think that's correct. Now we need to start on the dental aerosols. And the reason I look at this is I saw a great deal of marketing happening once those studies came out about the aerosol being suspended for 3 hours or more. And then we see different manufacturers coming out with ads like this.
Dental aerosols are some of the most dangerous contamination carriers in the dental working environment. Blood, nose, and throat secretions, saliva, bacteria, and viruses can all become aerosolized during standard dental procedures or surgeries. How do dental aerosols?
So, since the research on dental aerosols is extremely weak and poorly studied, unfortunately, we're being confounded with the bioaerosol research. What's the history of infections in a dental setting? Prior to the pandemic of SARS-CoV-2, there had never been any reported outbreaks of SARS, CoV-1, TB, influenza. There's no seasonal reports of increased infectivity in the dental community by the flu. Prior to the recognition of the pandemic, there were many people that visited dental offices. And we know that a high number of those people were asymptomatic or pre-symptomatic. So it's very likely that a lot of us or a lot of clinics around the country did see these patients. And if we go back to Wuhan and you look at the dental school study that was there, they certainly were practicing when the pandemic was unknown. And only about 0.4% of the dental professionals got ill, where their medical colleagues were many, 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 many times higher than that. Since shelter-in-place orders were softened, allowing dental services, the country has seen a surge in the number of virus cases, and the infectivity rates tested well over 20% in Arizona and Florida. And here in California, at one point, it was starting to get near 8%. So we are experiencing true community spread of the disease. And since it's believed that 4 to 5% of the population has had or had the disease, it means likely we've all seen these patients in the office, even with excellent screening. Yet still no reported clusters of dental care workers contracting the disease at workplaces. Germany had dentists practice through the entire pandemic surge, like I mentioned before, and there were no reported clusters in Germany. Like bioaerosols, are made up of many different particles in a dental aerosol. The larger drop, splatter, and spatter that we typically see, along with the particles, they fall to the ground very, very quickly. Like bioaerosols, the concerning particle size are 10 microns or less, especially the 2.5 microns or less that can penetrate deeper into the respiratory tract. Airborne droplet nuclei develop when the fluid of the pathogenic droplets evaporates. Okay, so they're small, light, and they can remain suspended for longer periods of time, like we've learned with the bioaerosols. And it's subject to air currents, humidity, and temperature. And that's very important, because if you create a negative environment, almost like a riptide from your suction, you can affect the surrounding environment. And I think some of the particle studies that I performed will show that. And we know that 80 to 90% of the human expiratory particles are less than 2.5 microns, and the rest of them are really 10 microns or less. Okay, so we need something that can measure those sizes. So about half a micron to 10 microns. Okay, the highest droplet concentration is certainly coughing and sneezing. Certainly patients do that during treatment, but not too many. We don't like coughers and sneezers in practices, so we usually send them home. So those high-risk individuals are usually not in the office. We know they're present during breathing and talking, but they're far fewer. Unlike the ballistic ejection and subsequent atomization by coughing or sneezing, its dental aerosols are greatly reduced with less seating, because we're actually introducing air that's diluting it. We're introducing water, okay? That cools the temperature, so their ability to have thermal rise is reduced. The patient is typically breathing downward with their nose right into our suction path, so we call that a nasal draw. So dental aerosols follow a completely different set of biophysics and fluid mechanics than that of the bioaerosols. And we talked earlier about the anatomy. So the location of virus-laden drops is farther down in the respiratory tract, and typically they don't live in the mouth or nose, except for some droplets that have been left behind when somebody does sneeze or cough. The pathogenic organisms are primarily confined to the tonsils, larynx, pharynx, and deeper into the lung system, and rarely at the front of the mouth where we find our normal flora. Therefore, an air-water mix from a device, either high-speed or piezo or water syringe, it can liberate loosely attached biofilms in the areas of the mouth, and then possibly from the tonsillar pillars in the anterior pharyngeal wall, but that's pretty rare. But some of that is mixed in the milieu of the jet stream that we create with a dental aerosol. So again, rather than a ballistic ejection of the bioaerosol, dental aerosol is a ricochet event. So imagine squirting water into a bucket. You get that kind of circulating effect, and it's also displacement. The mouth, just the volume isn't very much, and we're putting air and water into it. I think a handpiece spits out about 30 milliliters per minute, but I could not find how much air it produces, but it quickly will fill up the volume of a mouth, and then you create a displacement effect where that's going to come out as you exceed the volume of the mouth. Okay, and then so viral particles can be liberated and conjugated with proteins within the saliva. That's wrapped up into a moisture droplet consisting mostly of water, saliva, and mucus that's then liberated by our dental aerosol. The air and water provides great dilution though and temperature reduction. So I'm wondering how that affects an infective aerosol. That has not been studied as far as I know. So I think there's actually some positives that we get by introducing air and you can see that pretty easily right there. However, what we're seeing, we don't see the aerosols, we see the larger droplets. So that's the spatter and splatter. But we know contained along with that are the other sizes that we're concerned with. High volume suction greatly mitigates aerosols. So if we look at the Harrell and Molinari study and Gordon Christensen's work, we see that high volume suction or evacuation reduces aerosols by 95%. And how do you know you have a high quality suction? Well, there's lots of modern ways to measure it, but one way that you should look at is that you should be able to suck at least a liter of water in 1 minute or less. That's how you know at least you have an effective HVE system. So if we look at that video, again, no suction, get quite a good amount of aerosol that's exiting the patient's mouth. So with the suction activated, you can see it's not only capturing what's coming out of the mouth, it's actually creating a current drawing ambient air and that aerosol that's already exited back in. So you're creating that riptide effect like I mentioned earlier. And if we look at these, we look at the Cavitron, which is of course the one that's named as the most dangerous aerosol created by our dentists and hygienists, versus a dental handpiece. Now, I have noticed, I've seen the air version of the dental handpiece and the electric version. The electric version seems to have less of an air water flow than the air-driven one. I'm not an expert at that, but that's a simple observation that I noticed. So if we look at that, you'll see the cavitron is more of a circumferential, larger droplet dispersion, but we see that the dental handpiece is a smaller droplet dispersion and more of a jet effect. So it goes much farther. Matter of fact, I kind of measured it about 60 to 70 centimeters if I just shoot it straight up in the air. But the important thing to notice here is the farther the device is placed inside the cup that's there, the less spatter that's there, because you have containment within the environment itself. So you'll notice that as it's lifted out, you see more of an aerosol. So in this case with the high speed, the reason I don't like this shot is they never really put it farther into the cup. But this is showing that when it's contained within the mouth, you don't see a tremendous amount of aerosol exit beyond the high volume suction. And I don't know too many people that are engaging the devices prior to being inside the confines of the mouth. Okay, so farther out, more aerosol. And if we look at the stop action flow down here, so these are shots taken over, periods of seconds, and then snapshots are taken of the plume, the aerosol that's there. When the suction is activated, which is right about here, you can see it start to draw in the plume that's around it. So not only can high volume suction affect the immediate plume within the mouth, but it also creates currents that draw in some of the aerosol that's actually outside the mouth. And if we look over here, when we don't have an active high volume suction, you can see kind of a mist or a haze. And then when we activate it, you can see that the device, the jet, is being almost drawn in right off the tooth and right into the high volume suction, which is important to know because the closer, obviously, the suctionist device, the less aerosolization that happens. So good technique is probably just as good, if not just as important as the properties of the suction itself. And certainly devices like the Isolite and other devices that can be used to improve the positioning and the efficacy of high volume suction is probably a good choice. The other thing to notice is this. If we look at the efficacy of face shields, look how much that helps, having that as a protective barrier before we get to our mask, our last line of defense. So bioaerosols versus dental aerosols. There was a study, well, an article, I'm not sure how great of a study it was, in the Perio Implant Advisory that basically said that these are super dangerous and we really shouldn't be doing them. But if you look at the paper and you follow the quality of the citations, that's one of the great ways to look at some of these papers. You look at some of the studies that are quoted. A lot of times they're simply abstracts, and the studies here referred to typodont studies and confounding bioaerosols to dental generated ones, just like what's being done in the media itself. And all of them concluded potential risk, not actual risk. So since we can't see these dangerous particles without specialized laser and other lighting and high-speed cameras, how do we examine by direct or indirect measurements if aerosols are a concern? Well, there are things out there called particle monitors. And a particle monitor is a device that detects and counts physical particles. Particle counters are available in 3 categories. So you get aerosol, liquid, and solid, depending on what you're looking for. Selecting the correct monitor tool is important in monitoring whatever environmental condition you're concerned with. But in this case, we're concerned more about the aerosol particle. So we're going to select an optical device because they're relatively inexpensive and they're very accurate. It basically uses a laser light to count the particles as it enters into the sensor. The light source is blocked out by these particular size, and it's recorded into the machine and referenced onto a screen so that you can tell how many particles are in a particular volume of air, and it's usually in a cubic meter. And then there's condensation particle monitors that uses alcohol to and enlarge the incoming particles. And they can actually see down to 2 nanometers, which is far smaller than a individual viral particle. So who sets the standard for how many particles should be floating in the air? Well, guess what? For us as dental, it's not regulated. Nobody looks at it. So there's an international organization for standardization that sets standards for various business activities and conditions. And then we in the United States pick it up with different agencies. Some standards are adopted by the EPA, some are adopted by the American National Standard Institute. And you'll start to see these because the NSI or the NI or the ANSI is what you see on your masks. The AAMI is what you see on your gowns. ASTM you'll also see on certain masks. The FDA and the OSHA uses these things. They're clean room standards and hospital operating room standards. So it gets quite convoluted. So I'm going to go through these slides super fast just to show you how, sorry, a little too fast, to show you how convoluted things get. So the ISO sets the standard. Productive apparel, including gowns, are governed by a set of standards that test methods of all manufacturers. And these standards are established by the AMI. And specifically then the American National Standards Institute, they established the liquid barrier performance of each standardized test. So it's further confounded by that society. And then the Food and Drug Administration adapts both things and sets standards for gowns to pass. And then hospitals have to select the right AAMI level for whatever particular thing that OSHA tells them they have to do for each particular place that they have to use a gown, whether it's a contaminated encounter or a semi-contaminated encounter or a minorly contaminated encounter. So you can see how difficult and convoluted these things can get. So if we look at a clean room, a semiconductor room, where you can't really have almost any particles or the device will fail, you can see if you go down to the bottom and you look at the ISO level 1, so they can only have, for every meter cubed, they can only have 2 particles of 0.2 microns or greater and 10 particles of 0.1 microns or greater. That's extremely small. So if you want to be safe, away from the virus, go set up and live in a clean room, because that's the safest place to be. So we look at operating rooms, bacteria-free operating rooms. They're 5 to 6 class. Oh, quite a bit. You can get quite a bit of particles in there, okay? But again, the reason I mention this, so there's lots of these different institutes and places that make different recommendations, but we have none set for dental. And then if we look at the EPA, they set standards for the air. So they're usually setting standards for workers that are on non-PPE, you know, whatever their job is, doesn't require them to wear PPE, but what is the particulate matter that they're allowed to experience in their particular work environment? And if we consider what is safe, they say at 2.5 microns, you can't have more than 35 micrograms per meter cubed. And at 10 microns, it's 150. So if we use that as sort of a reference for what we call clean air, then we have at least something to go on. Okay, so if we look at air quality charts, it's made up of many different things, from the Clean Air Act of 1990, and all these things from ozone to particulate matter to carbon monoxide are all in it. But if we just look at the particular levels of particulate matter and how it relates to when our air quality is good or unhealthy, it's a good thing to follow. Okay? So are we safe? You know, one of the ways we can tell with a particle monitor is we can actually measure It has two ranges for this particular Dylos air quality meter. Remember when I said our expired gases or bioaerosols, the critical size is half to 2.5 microns, and the larger size is greater than 2.5 microns to 10. That's 80 to 90% of our expired bioaerosol. We can't detect viral particles in it, but we can detect the particles which would transport that particular virus. And we can do it very, very accurately. So the first set of the numbers on here are the small sizes, the 0.5 to 2.5, and these would be the greater than 2.5 to 10 microns. And that's going to be the majority of the dangerous bioaerosol sizes and the majority of the size distributions within bioaerosols and dental aerosols. Okay, so are we safe? So I took this test, and I want to give thanks to Anthony and Carliza Marcos in San Carlos, who allowed me to poke around their office while they were working. And so we started just looking outside. We measured the particles outside because we're always told, hey, go outside. It's a lot safer than being inside, right? Okay, so we see the 0.5 to 2.5 microns was 17.6. And the 10 micron size was about 34.7 micrograms per meter cubed. So let's do a positive control. Is this thing really working? So I set this up in my office. I made sure, in this particular case, I closed the door. I blocked off my vent. I made sure all windows were closed and the HVAC system wasn't on. It was a stagnant room except for my HEPA filter. I left that on, and I'll show you why in a minute. And now we're going to simulate an aerosol. How do I decide to simulate an aerosol? I used my Halloween fogging machine because it creates a hot, small particle disbursement, which is going to rise. So I'm trying to also sensationalize now an expired aerosol. So if we just take a couple of snapshots to develop a baseline, so at 220, the small particle size was 2.9 and the larger was 7.6. I have a second monitor over here. It's not quite as accurate, but I use that just for seeing how it would change over distance. And the jet was set at about 18 inches from the monitor. So just before, there's our baseline 3.0 and 7.4. On the other side of the 0.8 and 1.2. HEPA filters on. So short burst. And so again, positive control, we want to see those numbers jump. And that's exactly what happens. The numbers jump, so I speed up the machine. I try to put it right in the jet. Kind of wanted to go to the left for some reason. And you can see those are off the chart. It can't even measure it, that meter. That meters can't measure as much as this meter can. So after 1 minute and 6 seconds, we reached our max. And slowly over time, it started to diffuse. Remember, except for the HEPA filter in there, there's no way for this stuff to really escape. It's pretty much all being diffused and falling, and the bigger particles are eventually falling to the ground. So it took 7 minutes and 20 seconds for it to go away, back to baseline. And then after another minute and 20 seconds, you see actually the air quality improved because the HEPA filter was turned on. So if we look at results of some other tests I ran, the other tests, I just closed the room, no HEPA filters. It took 21 minutes to return to baseline. I opened the hallway door and the window, so I just have airflow. It took 6 minutes. Open the hallway door, window, and use the HEPA filter, it took 2 minutes and 25 seconds. So a lot of the CDC's previous guidelines where they said you had to let the room sit for, one time it was 30 minutes, another time they said 15, and it's constantly changing. Now they sort of leave it up in the air. They don't really tell you, but I think you can see with just a little bit of flow, the room clears out pretty quickly. And if most of your EPA approved disinfectants need 10 minutes to sit on the surface to be fully effective, I think that's perfectly fine to turn over a room. Okay, so positive controls. So we're now in a dental setting. We're going to use a cup and a high speed firing into the cup. And I forget exactly what he's grinding. I think it's some sort of Typodont tooth, but I'm not quite sure. But so let's see what happens. And sure enough, no suction, particles start to go up.
Oh yeah, so it's 6, 29, 9, 3, 32, 9, 9, 35, 10, 8, 39. Okay, good, let's kill it and see how long it takes to go down.
So I'm just gonna fast forward this.
Back to baseline. About a little less than a minute.
So about a minute, 4 seconds when we measured it on the video. Okay, so let's look at a dental aerosol in an operative procedure, right? We're all told, well, we should limit our amount of our aerosol generating procedures because, you know, they're dangerous. Well, let's see. So I turned off the HEPA filters and made sure the windows were closed so that we would try to have as much stagnation as possible. So look at the meter numbers. Those are our baseline. This is verifying I've closed the window and turn off the HEPA filter. And I'm about 2 feet from the patient, but that's not that accurate. I never got more than 2 feet, probably more 18 inches to 2 feet. You'll notice the isolite is on. Okay, so now if we believe what we're being told by our public health officials, this monitor should jump.
You want to touch the water, right?
So even getting it closer, probably well inside 18 inches now.
I think your screen view, just look at me.
Okay, no worries.
So I can feel the air on my fingers, but I'm seeing absolutely very little change in protocol.
And remember, the EPA says that that first number can be up to 35, and the second number can be up to 150 and considered clean air. Also, you'll notice how much less particles there are in the air in the office than versus outside. Now, this is what I found interesting. Actually, over time, with the high volume suction on, the air quality or the particles within the air actually are starting to go down, which is supporting that riptide effect of the high volume suction, creating a negative pressure that affects a surrounding amount of the circulating air. So it actually draws particles in from outside the mouth.
You know what this score is?
Okay. All right, so here we're going to look at an ultrasonic assisted Profi procedure. So this is supposed to be the biggest danger procedure that's performed, right? So there's our baseline, 5.6 and 18.5. The only device being used is the X suction device. So the device is active. The reason I mentioned that is we're starting to see a decrease from the original baseline. So I think it does have some sort of air scrubbing effect. And now here comes the ultrasonic, which again, the most dangerous thing that we could ever use for the coronavirus. This is the great white shark in the water. So after 4 minutes, we're actually seeing a decrease in the amount of particles circulating in the air. So let's look at this one. This time I'll be a little farther out because remember, these aerosols can get to many, many feet away that we're told. So I'm about 36 inches away in this particular setting.
You get science credit too.
Yeah.
You get science too.
So it's the same as the ambient, so it doesn't really change, and it's less than like, what, 3 to 4 inches from the mouth. So there's actually a less particles if you're suction closer than it is here.
Yeah, that's on there?
That's on it.
Oh, why?
It's going to in like. There's some also battling that.
So let's fast forward a little bit and get even closer.
So that stuff is up to like,
Oh, yeah.
honestly, that is
Oh, yeah.
very small change. And then minuscule.
You okay, Julia?
Keeping that phone much
That's good after this.
And look at the distance towards that, maybe
You're
8
like-
inches.
Yeah. And we're like, what, 2 to 3 feet away?
Right.
You know.
Oh,
So after 4 minutes, we actually see a drop in the amount of particle volume that's being detected.
Filling.
Oh,
Still have
yeah.
isolated.
Okay, less than 12 inches. And then we're actually going to show that when we're turning the high volume suction off.
I like that.
yeah, but is it coming all the way to here? Nope. I put it right there, literally.
Now you can see
Yes, now it's like.
the spatter and splatter,
It's
but
definitely going up.
But we would never have no suction on.
Right, and you would never.
and so you do see a small rise in the monitor when the suction is not on.
Really?
Sorry about that.
That's sorry, Emily.
Good job.
Thank you for being
You're helping
a guinea. Yeah. Testing.
This is, give you class credit for the science project.
There you go.
And so you also notice there's a little delay, and that's because, remember, the aerosol has probably been transmitted around the area and it's now starting to settle. So the particle monitor is picking that up.
Next thing up to is cultures in the air on a positive station.
I did, I tested the water line. That was my science experiment for the week. Maria said that half the.
And now you're starting to see the particle volume starting to fall.
Okay. So now all that stuff that was suspended is now gone
Already?
already. So they're saying you have to wait,
15 minutes.
30 minutes.
That's another thing that Jana's really concerned about too, is how long they stay in the air. She thinks 45 minutes, I think.
What? All bullcrap. Because the science.
Okay. So the takeaways from the particle observation is clearly the particle monitor experiment, as rudimentary as it was, it showed that the particle load during dental procedures with adequate HVE did not create a significant and potentially dangerous dental aerosol. Because remember, we're actually measuring the particle sizes that are critical for carrying virus. Moreover, it appears to be effective to affect the immediate surrounding atmosphere positively. This may explain why there's never been a cluster of respiratory-borne disease in the dental field. By no means should the dental aerosol be confounded by bioaerosols. They're completely two separate things. More studies have to be done to reveal the biophysics, fluid dynamics, and aerobiology of dental aerosols, and it's desperately needed because without it, we're going to have regulations and mandates placed upon us based on bad science. At minimum, science needs to understand the dental cloud dynamic flow by high-speed camera imaging, varying lighting techniques, image extraction, mechanistic modeling, and we need to have solid data so that we have a negotiating platforms as various dental bodies create policy that dictates how we're going to operate as dentists. With every day, recommendations from various respected sources change and waffle almost daily. Due to poor data, and the embedded hypocrisy is confusing and creates uncertainty in the profession and the public. My case in point, on June 17th of 2020, the CDC put guidelines out for engineering controls. They said that we should consider the use of upper room ultraviolet germicidal irradiation as an adjunct to higher ventilation and cleaning rates. Yet farther down the article, they say the efficacy of alternative disinfection methods such as ultrasonic waves or high intensity UV radiation is not, its effectiveness against COVID-19 is not known. That's great. You make a recommendation and then you tell us we don't know if it works or not. It just drives me nuts how that's consistently happening. Okay, so takeaways from the particle observations, we definitely need more data, okay? And I think that also will start to show that we probably need to look at the air quality within the offices and have some minimum standards regarding that, since there are none for dental. And is local scrubbing good enough? Meaning if our local HEPA filters are good enough. I think they are, but I'm not quite sure, okay? You should be quite concerned, again, how policy affects your practices. They're being decided by uninformed and poorly informed experts. Our advocates can only argue for us based on solid evidence, which unfortunately our dental schools and universities have failed to produce for our advocates that are fighting for our rights with our government. Based on bioaerosols confounding and lack of understanding, dental aerosols and some counties' health orders still have restricting language. Utilize a rubber dam. I think a rubber dam's fine, but it's a passive restriction, or it's a passive mitigating factor. An active factor is your suction. Where possible, minimize and perform any aerosol generating procedures. Well, I think we just showed that I don't think that the aerosol generating procedures are dangerous if you use proper HVE. We need to eliminate the ultrasonic scalar because that's the most dangerous instrument known to mankind right now. I think that's absolute fallacy. Try to have an aerosol-free hygiene visit when possible, and some county orders still refer to emergency treatments only. That's insane. Based on the particle information gathered, those recommendations do not seem appropriate. So is there a place for particle monitoring in the office? Well, you can get them. They're pretty cheap. I mean, this one that I got is pretty expensive, but this guy down here, this Temtop P1000, it's $100. You can get it off Amazon. This Dyson HEPA filter actually has one built right in. So you don't even buy anything else, although this is a little expensive, this air filter, but it's got one already built in. I don't think you're trying to measure trying to do any kind of super research, but what I think it can help you do is evaluate the effectiveness of your suction devices and techniques. So if you start to see spikes in your particle sizes, you may want to rethink how you do those things. And then you may want to get one of those, those giant elephant suckers. Although I think I've shown you really don't need them, but if you're constantly seeing spikes, then that may be a nice adjunctive piece of equipment. The other thing that can help you do is know when your room is clear. And it can also show you how effective your HEPA scrubbers and your HVAC systems are, okay? So do masks work?
To blue lab
I know we're running out of time, so we look what they did in this situation is they took Petri dishes, he coughed with and without masks, he sung, he yelled, and he just spoke lightly, and they did different cultures, and consistently, the cultures where the masks were didn't have any growth. So do masks work? Absolutely they work.
Pretty prevalent. 6 feet. Oh, okay. Yeah, just one or two few up there. So there really is that distance difference where the droplets that you're producing by coughing are pretty much, a lot of them are falling out of the air. To me, I think we're coming into a new reality where masks fit into that very social conscious paradigm. You do simple things that everyone can do. It's not going to be 100% effective, but if we all do it, it's going to definitely make a difference in preventing things from spreading one person to another.
And that's key. We all have to do it. So do masks work? They absolutely work. I went through this on a previous lecture, so I'm not going to beat a dead horse, but there are a plethora of studies comparing the two masks together. And really, but it's based mostly on an influenza model, which is about roughly the same size virus. And they found really no statistical difference between the two. However, if you are going to use a level 3 mask, I would strongly recommend that you get some mask fit modifiers, like the Bellis one here, or the Fix the Mask strap, just to create that seal. Get rid of that seal where it beads up right here. That's where the opening in these level 3 masks are. If you feel better with an N95, I'm certainly go for it. There's nothing wrong with that. The only problem is oftentimes the suppliers will change the make and model. And remember, your fit test is only good for the same make and model that you have, okay? And there was a recent study that I did find in the Lancet that did a retrospective study, and they did protectiveness over level 3 versus N95. They used may be more protective. They didn't use is. So again, research is out there that shows that maybe N95 provides slightly more protection. But again, if we go back to the Germany model, there were no reports, and they almost always used just a face shield and a level 3 mask. However, I think this is very important that they used open air ventilation. And if you really want the ultimate of protection, the PAPR device is the way to go, but they're very expensive. And the batteries, although they say they run for 8 hours, I'm told they run maybe 4 or 5. So you're gonna have to buy another battery pack, which is pretty expensive. And do masks work? Absolutely. So, but a lot of people are complaining, especially with the N95 masks, that they can't breathe, that the CO2 levels build up, their oxygen levels get poor, start to fall off, and it's dangerous. Well, we know that there really is no medical restriction for masks. People with mild to moderate obstructive disease shouldn't be an issue. You can still draw on air. You do still have a functional reserve volume. It still should work pretty well. Asthma is a common thing that people say, I can't wear a mask because I have asthma. Asthma is a disease of expiration, not inspiration. So that doesn't make any sense at all. Now, there are people that wear the N95 that experience claustrophobia and anxiety. That is an issue, and that's something that you have to work with to get over it. And I think frequent breaks would help. But as I discussed before in a previous lecture, there's no really long-term damage to the N95 unless you use it for very, very long periods of time. There can be some pulmonary injury because of the increased negative pressure it takes to draw in the air. Your body will compensate and do it, but there does appear that over long periods of time, you can have some pulmonary injury. So the mitigating factor there is you just take breaks. Get the mask off, take a break, breathe in some air, because things are hot with all of your PPE. No matter how good your air conditioning is, you're going to get hot and sweaty. Give yourself a break, okay? It's so easy, especially in the summer, to become overheated. There have been reports of heat exhaustion, so take breaks throughout the day and certainly hydrate. It's been reported that heat exhaustion in the warmer areas of the country, so again, take breaks, okay?
The ability to reduce your oxygen. That is medically false. A public service announcement, if I can, about mask wearing and oxygen saturation. This on my finger records the oxygen saturation of my blood and my heart rate. This top number is the oxygen saturation. Anything between 94 and 100 is completely normal. I have no respiratory conditions, so for me, it sits around 99. The bottom number is my heart rate. Anything above 100 is too fast, and mine is fast because I'm pissed off that I'm having to record this video. Now, I'm going to put a mask on, something that I do routinely, seeing as I work as a surgeon, and I'm going to show you that actually this oxygen saturation number doesn't change. Masks do not have the ability to reduce your oxygen.
Okay, so let's just scrub forward a little bit. This guy put on 6 masks. I wouldn't suggest doing that. Probably run up your costs of your practice a little bit. But we're seeing no change really in heart rate, no change in saturation levels. Okay, that's the problem, is to get.
If we could get everybody to wear a mask right now, I really do think over the next 4, 6, 8 weeks, we could bring this epidemic under control.
Okay, so I took it a step further. I instead of using a level 3 mask, I got a well-sealed previous fit test 3M 9210 NIOSH approved N95 mask. I took a CO2 sampling line, which you can see in the arrows here, and just to prove that, and just to make sure there was no leakage, I put a transport tape around that sampling line. So we're going to test now to see if CO2 builds up, because they were testing oxygen saturation. Let's see if CO2 builds up. So we note the time is 1634, SAT is 98, expired CO2 is 38. If I'm retaining CO2, that expired CO2 should rise. So at 7:11:35, my expired CO2 is 38. And my oxygen saturation is 98, and my heart rate is essentially unchanged. So after 37 minutes, we saw no buildup of CO2. So are we safe? Remember that we only have to break one part of an infection cycle to stop the disease. So when you're designing things for your office and you're talking about screening and environmental controls, engineering controls, PPE, you're attacking each one of these spots in the chain of infection. So just remember that every time you're trying to design something. Dental offices are one of the safest places to be. An article that was based off a research paper from MIT said that we're literally in one of the top 5 safest businesses to be in. Okay, we're certainly safer than, again, Trader Joe's, Costco, Home Depot. It's not even a close comparison. What mitigating factors do they have in play when you go there? Do they distance people anymore? Do they check and make sure your masks are on? What level of masks do they have? What environmental controls are they using? When you come to a dental office, all those are in play. What other screening do they do? They let anybody in. They're not even taking temperatures or doing any kind of screening. So the ADA said on June 22nd that 97% of dental practices are open, 85 are paying staff fully, 65 have reached pre-COVID levels of production. I'm not sure how that's possible with the distancing, unless they're increasing their hours or days. So based off this and the current community spread of the virus, certainly many dentists have seen and treated pre-symptomatic and asymptomatic carriers. And again, no clusters of dental healthcare workers are testing positive during contact tracing of patients. So it starts with a coordinated office practice. I'm going to go real fast here, guys. I'm almost done. Develop a list of protocols that everybody can work through for the design and flow of your office. Breaking the chain starts with screening. Prior to the appointment, screen these patients the day before. Most people report what they're asked. So if you're not asking enough questions, you aren't going to get a good response. If you just ask if they feel sick, they may not say anything. If you had a cough, they may just say no, but they may have lost their taste of, lost their ability to taste or smell, but if they're not going to offer that up unless it's asked. They may not disclose that they, yeah, I don't have a fever, but I've been pumping in Tylenol and Motrin like it's going out of style. You got to ask that thing. They may not disclose you. They really can't smell or taste things funny like they said, or they have GI symptoms. Studies show that one of the reasons there are so many asymptomatic carriers and pre-symptomatic persons has something to do with the questions that are asked. And when you start to expand what you ask, you start to get more positive. Start with closed loop questions. Don't let them ramble. Ask them specifically what you want. Still doesn't catch everything, but you're going to catch more than just the standard. Do you have a cough, fever, and have you had any contact with a COVID positive patient? That's insane. So checking temperatures prior to entering the facility, don't let them in until you've taken a temperature, because you don't want any area of the facility possibly contaminated. I would consider cutting it off at 100 and make sure they haven't had any antipyretic medicines in the last 24 hours. Otherwise, your data is poor. Check and screen all employees too before starting the day and record those in a log. Screen the patients before, again, they enter your facility if possible. So this is what I do, and it changes all the time. You know, now we see that there are mouth sores found in COVID patients in conjunction with what's called urticarial exanthem, similar to what we see with varicella zoster. They'll not only have this rash, but they'll feel the pins and needle sensation. That's something new, and they're reporting now 15 to 20% of people have this. We see the little COVID toes and COVID fingers. This finding is actually becoming more and more common, and that's because the virus is changing. It's a different virus than the one that was in Wuhan, and this one has more cutaneous findings than the ones in Wuhan. So this is the one I use, and I've probably changed it 5 times since I started it. Okay, this is the one I use in June. But one of the things I want you to see here that you should be asking, because these are the high-risk areas, not only fever, muscle pain, stomach cramps, GI symptoms, stuff like that, okay? But this, I do not live at a long care facility. I haven't visited a long care facility, a nursing home, or assisted living. That's very important, because those are very high-risk environments. Remember that breaking the chain, that type of environment is where high-risk patients may come from, okay? Make sure they're wearing the right mask when they come in. I still see a lot of people coming in with these valved masks that they don't protect on exhalation, so swap them out and give them a mask, but don't let them in. Up here, you probably can't see this because there's my picture's up here, but if you minimize that, you'll notice there's somebody wearing a mask, a nasal shield that you might want to have your patients wear when they're in their office. Make sure you keep your appointment short, and your typical routine follow-ups can be conducted by phone or a HIPAA-compliant video call. And now the patients can see your face. The less encounters, the less risk. You increase your availability of your office space because you're not having them occupy a room for a simple follow-up. And try to schedule your high-risk patients appropriately. So at the end of the day, at the beginning of the day, or maybe right after lunch, after the rooms have been cleared and fully cleaned, and you can isolate that high-risk patient. Not only high-risk patient for capturing the disease, but they may be a high-risk patient, even though that they passed screening, could be a possibility of a carrier. So this would be like somebody maybe that's at a nursing home, okay? Patients should be by themselves. Rides can stay in the car, and they can be called or text when the patient is ready. If a parent must remain in the office, then make sure it's only one family member. Same with caregivers. Everybody should say masks at all times. And now this is tough for your pedodontists and orthodontists when you got young kids and you got autistic kids. Well, these guys may not be able to wear a mask. And we know that a lot of these kids are asymptomatic carriers, although a lot of research is showing they get the disease less, because until you're about 11 or 12, you only express about 60% of the ACE2 receptors. So that's showing why the kids are probably more likely to be asymptomatic carriers, because they don't have as many receptors as us old people do. Patients should sanitize upon entering the facility. Be careful, some sanitizers now are contaminated with methanol. Try to have as many touchless items in your office as possible. All staff should frequently hand wash. Try to do what we do in the hospitals, meaning anytime you enter a patient treatment area, you foam in, and then when you leave, you foam out, okay? Which means you're using disinfectant in, disinfectant out. And it's sometimes wash your hands, because believe it or not, washing is a little bit more effective than disinfecting, and some studies that have been done. However, both are fairly equivalent. Consider sneeze guards where appropriate in your office. Mark off proper distancing and patient flow. Remove all fomites. Get rid of everything in your waiting rooms. And you probably even shouldn't call it a waiting room anymore, since we don't want people waiting in the rooms. Cover all your keyboards and all your equipment. Consider online payments or touchless paying solutions. If you have to touch credit cards and stuff, immediately sanitize your hands and try to pick up the card with a tissue paper. And as soon as you guys get to work, put your phones in a sealed baggie, because that your little phone cases that you have, these are great little things for viruses to collect on. Okay. Put off your office signs about your hygiene and what you expect the etiquette in your office to be. And people will follow them if they see them. Try to have your rooms completely set up prior to seating the patient. Avoid opening drawers and cabinets unless absolutely necessary. So consider, as soon as a patient gets in the room, consider that room contaminated once they're seated. So if you've got a lot of things you need to get in and out of when patients are there, you might want to consider moving them out. I know it's a pain, but somebody can bring them in if you need them. Okay, point of care testing. This could be a big help in our practices if we could have accurate, quick point of care testing. I still think it's funny that some of these Cepheid systems where you need a good nasal swab, that the board doesn't believe that dentists are qualified to perform a nasal swab. And actually these tests are now pretty darn accurate, at least testing for the antigen. So you see these threshold cycles, these what's called CT values that are here. We know that they're sort of inversely proportional. If you look, as the CT value goes down, the level of copies of the virus go up. So it's an inverse, again, proportion. And we know from plenty of people that are asymptomatic carriers, and then patients that have cleared the virus are no longer infected, the CT value is 34 is critical. So you want something that can see at least that number to know if it's an accurate assay. And this Cepheid system that they have is very good. The nice thing too about this system is it can test for influenza A and B, which is going to be nice in the winter when somebody comes to your office and they're, may have had a cough or a fever. You'll know if it's influenza A or SARS-CoV-2. Probably still shouldn't treat any of those patients, but they can quickly return to your office. They have this one, they're going to be out of your office for quite a long time. Breathalyzers and salivary tests are coming to the market soon for rapid testing under 5 minutes, which is really going to be really good. This test here can take between 10 to 35 minutes, depending on how many cycle values it has to go through. Okay, I can't, this is my big one, is you got to come to your work in clean clothes, whether that's your work clothes or not. But when you're done at the end of the day, leave the clothes in your office if you can, and either launder them at the office or have a laundry surface. Believe it or not, I read a few studies that some of these people getting community spread are coming from their dogs. And why is this possible? The dog's hair is designed to keep fluid towards the top and away from their skin. So they go to your dog park and somebody's been, coughing and sneezing, but they got their mask on, but their hands now contaminated. They pet your dog, or maybe they pet their dog and your dog rubs up against it. You come home, you pet your dog, and there's your transmission. So have your dog on a leash, and dogs can't really play with each other. We can't have the old dog sniffing here, which is bad because that's how I get my dog to take a pill. I tape it under the tail of another dog, but guess we can't be doing that anymore. So keep your dog on a leash, okay? And so back down here, there's some evidence that you let your guard down when you're doffing your final PPE for the day. So take your PPE off in the operating room. And when you get to your changing area to go home, be very careful, because some of the suspended micro droplets may be on on whatever you're taking off, your scrubs. And if you do it very violently, you can resuspend those aerosols, and there is a potential for transmission that some studies have suggested healthcare workers contracted the disease this way. So when you're doing your final changing, be in a mask and wear gloves, or immediately wash your hands or disinfect your hands and then remove your mask and exit the building without your shoes. So come and leave your shoes at work. Okay. There's plenty of other stuff you guys can read here on the replay, or you're reading it as I'm talking. So other engineering tips, we talked about directional airflow. Just make sure that the flow is out. So have a door open somewhere that's bringing fresh air in, and then have a fan blowing air out of the operatory, so you create that vector of flow. You don't want to bring air in through your operatory and then in through circulating your office. Try to create a flow like that. So you can have a fan blowing air in from an open door or an open window somewhere where there's not patient treatment into the areas where patient treatments are. Open a window with the fan pointing out. You can also put the exit portion or the exit vent of your HEPA filter out a window, okay? But the HEPA filter takes in air and spits out clean air, so that's less of a problem. You can also talk about HVAC system. Again, there is no real standard, and we currently need some sort of standard, but talk with your landlord or your HVAC person to make sure you at least have a MERV 13 filter. Now, so if you don't, it's sometimes difficult just to throw one in, because the added resistance could blow take out your blower. So you got to make sure that your system's capable of doing that. If you can, have a HEPA filter put in. Try to figure out what your exchange rates should be. You want it greater than 12 if possible. So your HVAC guy has a very simple monitor to detect that. It's called a manometer. And at least put a UV light in. A UV light can be put in any system, but unfortunately old HVAC systems have a recycler. So oftentimes it's recycled air in your air conditioning, which is maybe the worst thing, because all you're doing is taking the same air that's there and you're spitting it back out. And there's been some evidence in China that they believe that that is a mechanism of a super spreading event at some restaurants. So watch the UV lights where they are. If they're deep within your HVAC system, they're probably okay, but some wavelengths do create ozone, and the higher wavelengths of 254 or higher tend not to. Ozone's a little bit dangerous to have high concentrations in your office for health purposes. And watch UV bulbs, because if they're not LED, they're regular UV bulbs, they have mercury vapor, which is a big problem if you drop it. Consider fogging, that can certainly help. And I would consider electrostatic fogging if possible, because it charges the whatever fluid, either alcohol or hypochlorous acid, as it comes out, and that is attracted and binds to inanimate surfaces rather than just getting everything wet. And cover your toilets. Believe it or not, the virus lives a long time and is transmittable, even though you're not having symptoms in the feces. And so you re-aerosolize that when you flush the toilet. So make sure you have toilets with lids and have signs to close the toilets. And there are the studies that show that this is a mode of transmission, and it's happened in hospitals and patient rooms when the maintenance people came to clean. Those people got sick, and they think it was from this transmission. Make sure there's some air filtering done. Cover your ultrasonic cleaners. Make sure there's air filters in your sterilization area, because the ultrasonic cleaners definitely can resuspend stuff. COVID-19 patients usually will have symptoms day 1 to 4, but it can be as long as 12 additional days, so you can't use that as a guideline. Higher risk patients with comorbidities are especially susceptible to the disease if they get it. So you may want to schedule those people appropriately, maybe when they're the only patient in the office or very separated from other patients. If somebody's COVID positive or suspected COVID positive and must be treated, you got to refer them to a hospital-based facility that has at least a negative pressure room, and that's a recommendation for now. So you don't want those patients in your office unless you do have negative pressure. So what happens if a COVID positive patient comes in and needs emergency treatment? What do? Because it was mentioned earlier, the viral shedding can happen for up to 30 days. So it's be safe to schedule 6 weeks out. Emergencies sometimes can't be palliated for 6 weeks. So You can obtain medical clearance, have their physician decide if they're cleared and not infective. A lot of times they won't do it. They just say it's too much liability on them, or the patient won't comply with serial testing. So if they've had the disease and completed home isolation, they have to meet the following criteria. I would not use non-test based clearance, but this is one of the methods that Department of Public Health says you can use. At least 3 days have passed since the recovery, which is defined as resolution of fever without the use of antipyretics. An improvement in respiratory symptoms, complete resolution, shortness of breath, cough, and at least 10 days have passed since symptoms first appeared. But we know about this, so I don't know if this is any good. Test-based, you have to have resolution of your fever without the use of fever-reducing medications, improvement in respiratory system, and a negative COVID PCR from at least 2 consecutive nasal pharyngeal swab specimens collected greater than 24 hours apart. That is, I think, decent science. Regardless, check with their health provider about their status and get advice and confirm to the best of their knowledge they are not infected before treatment is rendered. Blood O type, if you got it, you seem to be a little bit protective. Type A, not so good. These people get sick. And I just want to show you, there's one study up here that showed in the Annals of Internal Medicine in a prison, in North Carolina prison, only 4% of the inmates that tested positive for SARS-CoV-2 showed symptoms. 4%. Now that is an anomaly, but that is shocking that 96% of the people that were infective and capable of spreading the disease had no symptoms. Okay, keeping your immunizations up to date seems to be protective. Stop smoking, get your rest, nutrition, take zinc and magnesium, and make sure you exercise. Again, COVID positive patients, if you can, schedule them 6 weeks out. Okay, antibody tests are still unreliable. Okay, other corona antibodies give false positives, so it's still in the debate. And debate, do we have immunity? We don't know. We simply don't know yet. We don't know what that titer level will be. Clearly, those antibodies fall off, but at what point does it fall off where our body won't respond? We know it very well in titer levels for hepatitis, but we don't know it for this disease. Should patients rinse? It certainly helps, but remember it's fleeting. So it will it will help reduce by a log of 4 when it's introduced, but as soon as they start breathing, coughing, doing whatever, it repopulates those airways pretty quickly. However, it can't hurt. Just want to point out that if you do use peroxide, they probably need 2 rinses because the first rinse, bacteria secrete what's called a catalase, and it deactivates the effect of the hydrogen peroxide. So if you do use hydrogen peroxide, they really need 2 doses. I wouldn't buy it. It's awful expensive. You can take regular hydrogen peroxide, which is 3%, dilute it 1-to-1 with your favorite tasting mouthwash. That makes a 1.5% solution, which is very active against the disease. And go ahead and give them that. It's a lot cheaper and it's a lot more available as well. They use in Europe, they use the betadine rinse and they actually have them swallow it. Nothing wrong with that either. But remember, it is short-lived, but it could be a good thing for patient perception. And remember, chlorhexidine, at least at 0.12%, that's typically in the mouthwash, is not effective. We do use chlorhexidine for skin preps for doctors that are iodine sensitive, but it's also packaged with 70% alcohol. So that's why it's effective against the virus in a skin prep. So are we safe? Well, this is pretty much showing that we've kind of turned the corner, at least on treatments. Before, when 80% of those patients who went on ventilators, they didn't make it. We've cut that down to about 30% now. And treatments like immune modulators that you see here, rivaroxaban, which is decreases the thrombotic event. You probably have seen these things like they're like Eliquis. There's the factor 10 inhibitors. They help quite a bit with patients having the thromboembolic events. Remdesivir does show to reduce the severity and the length of time patients have the disease, but it's not quite the wonder drug. It was supposed to be likely there will be more therapies to reduce the severity of the disease and the damage from our own immune system before there's a widespread vaccine. And I'm just showing you there's lots of vaccines that are out there. Remember, this is a RNA virus. They tend to mutate. We know that the virus has already mutated many times. Are we going to find a part of the virus that doesn't mutate that we can create a vaccine that's going to create a response? We do see that a lot of these vaccines have both T and B cell responses to them. So keep our fingers crossed, because this will be the best way for us to get back to normal living.
There will be no return to the old normal for the foreseeable future. But there is a roadmap to a situation where we can control the disease and get on with our lives. But this is going to require three things. First, a focus on reducing mortality and suppressing transmission. Second, an empowered, engaged community that takes individual behavior measures in the interest of each other. And third, we need strong government leadership and coordination of comprehensive strategies that are communicated clearly and consistently. It can be done. It must be done. I have said it before, and I will keep saying it. We weren't prepared collectively, but we must use all the tools we have to bring this pandemic under control. And we need to do it right now. Together, we must accelerate the science as quickly as possible, find joint solutions to COVID-19, and through solidarity, build a cohesive global response. Science, solutions, and solidarity.
Thanks for your time. So I hope we'll be back to normal pretty soon, but I think it's going to be a while. So take those measures that we mentioned here, and I think we need to get some research going on our dental aerosols so that when we do see mandates coming down from OSHA, which are definitely going to come, and our public health department, that we won't be over-regulated, which I fear in the current condition will happen. Also, if our numbers start to go up, if we can prove that our facilities are safe, then it's very likely we will not get shut down again. But thank you very much for your time. Please send me all the questions you want. I'm sure we've generated quite a few, but I hope that we showed that at least dental aerosols aren't this lethal thing that so many people believe they are.
Bruce, thank you so much. We wanted to ask you a few of the questions right now.
Sure.
Did you measure any cavitron without HVE and only a saliva ejector?
So we did do, I don't have, I mean, if I showed all the videos that I took, we'd still have a couple hours to go. And yes, when we removed the high volume suction, you did see a spike in the particulate matter, both in the small and large sizes.
But did you ever have no HVE and just the saliva ejector?
No, as far as I know. Well, there were periods of time we did have the saliva ejector on briefly to capture what was already in the mouth, and we turned the high volume suction off. And then there were periods of time without the low speed suction on, and you did see an increase, but I didn't test that over long periods of time, because as soon as you turn the high volume suction off, you did start to see spiking of the particulate matter.
All right, sounds like we need to use our HVE. The next question we have is about level 2 masks. Since it's so difficult to find level 3 masks right now, is a level 2 mask effective for procedures such as Profis?
So if you look at the ATSM rating on a level 1, level 2, level 3, with a level 3 you're getting 98 to 99% of 0.3 to 0.1 microns filtered. That's 95% at level 2. So it's a small drop off, but the big thing with level 2 is it's far less fluid resistant than level 3. So you got to make sure you have a face shield.
Okay. All right. That sounds
If that's what you got, I think you're pretty safe. And I think whatever you do on the traditional masks, make sure you have a fit modifier.
okay. And then one last question. We thought the recommendation was to close the door for operatories, and you had mentioned having the hallway door open and the window open. And
I think closing the doors and then closing it off, yes, you're keeping whatever's in there, but you're also concentrating it.
okay.
So I think the dilutionary effect of having air flowing in, and I mentioned creating an air vector, right? So you should be bringing air in from the outside into the hallway, into the room where you're operating, and then hopefully you have a window in there that you can exit. So point the fan out the window, and that way you're not only diluting the air that's in there, you're making the air go out the window. I mean, that's the ultimate. You want to blow it. That's what a negative pressure room does. It basically sucks all the air in, and then you have a vent that's going outside. Either it's filtered and vented out or just literally vented out into the air. That's how they create a negative pressure room.
All right, Bruce. Well, thank you so much, all of us from SMCDS, and for everyone joining us tonight. Thank you. The meeting was recorded, and it will be posted on the SMCDS Facebook page. And we want to thank the SMCDS staff for putting this on. And everybody stay safe and enjoy the rest of your night.